First question is, can the weakened tongue muscles be trained with long-term success? Can the weakened tongue muscles be trained with long-term success? Sorry.
As long as there is no atrophy of the, in the nerve, as I was just saying, or, like upper neuron, lower neuron, like issues, it is just bad habits. It is doable. We have done it and it works perfectly. Like we have done it. Yes, you can strengthen the tongue. The tongue muscles is just like your calf muscles. Is your arms, your legs. You go to the gym, you exercise them, you make them stronger. The same thing with your, like tongue muscles. The problem is, or the issue is, you need to make sure that you are doing them right. Your patient is doing them right.
Excellent. Thank you. Next question. Will mild functional therapy cure sleep apnea for some patients?
Based on the literature, if it is mild to moderate, they say yes, it does, but not severe sleep apnea. And that is, there is a lot of articles that were written by Joy Miller. That if you can, review them,
Right.
that, like she mentioned that.
Okay. So I think you answered the second part of it. Or can it reduce the severity of sleep apnea patients? So if you have a severe case, can it at least reduce it, not treat it?
Oh, yeah. Like also based on the literature, you can reduce it, but you cannot treat it.
Okay.
Like I hate, like I hate when like somebody wants to be somebody else. I'm not a sleep apnea specialist.
Right.
I'm an orofacial myologist. My job has something to do with the sleep apnea. So I work with the sleep apnea specialists. And I tell all my students that please make sure that you work closely with the sleep apnea specialist.
Okay, thank you. Next question. What are your thoughts about mouth taping to retrain patients to switch from mouth breathing to nasal breathing? Mouth taping, sometimes referred to as lip taping.
There are a lot of people out there that are supporting it. I am not personally, because I don't think it is natural, and I want to train the lip muscles to be together, and gradually until they get to the point that they can sleep with their mouth closed or their lips together. Is there people doing it? Myofunctional therapists doing it? Like they are supporting it? Yes. Do I support it? No, I don't. Just because it is not natural.
Okay, okay. The next question's a little complicated. I'll see if I can present it in the way I think it was submitted. Is normal oral posture with lips together, teeth apart, or lips together with teeth in light occlusion?
Of course, lips together and teeth on very light occlusion. That is always the good resting posture. And that is why, like I'm sorry, can I elaborate a bit here?
Absolutely.
Okay, so if we have the like if you ask your patients sometimes, like if you like you ask your patients to go with the like, oh, they can do that with people that have sleep apnea and TMD. But when you ask them to go, when you ask them even to go low note, oh, they can do that. But when you ask them to go high note, ooh, they can't do that. And that's why I want to share with you this, something here. I don't know if you know Dr. Enoch Edmonton.
I don't know.
Okay, so Dr. Enoch and Stephen Arnold. Okay, so this is like an idea. I was teaching it, and then he jumped in and he said he want to do a research about it, and it is. I found out that people with sleep apnea, and this is like he sent it to simple facial movement science as an indication for all facial muscular involvement in temporomandibular dysfunction and sleep apnea. So we are testing, like winking. And this is, we are trying to wrap it up now. It is a research that, like it's taking for a very long time. But, research, do take long time to, like I ask my patients, please, can you wink? And they can't do that. They really have a problem winking. They have problem going with the high note. And people say, oh, why not the low note? Okay, again, the low note and the high note will take me to the infrahyoid muscles and a lot of muscles, the omo, a lot of, I don't want to go into it. But because the only muscle that is responsible to do the high note, the in the infrahyoid muscles is one muscle, is actually the sternohyoid muscle, the thyrohyoid muscle. All other muscles are responsible from the low note. Oh. So the one muscle, why that one muscle? I'm testing it because I do think the infrahyoid muscle, if you have a weak sternocleidomastoid muscle, then your infrahyoid muscle start to compensate and then affect these muscles. And then how do you know? By assessing the thyrohyoid muscle with the high note.
Okay. All right. Thank you. Are you finished? I don't want to cut you off.
Yeah, no, I haven't.
You said you could talk all night, so you might be here for a while. All right, next question. How often do you find that patients with motor nerve problems also have sensory nerve problems?
Can you repeat, please?
How often do you find patients with both motor nerve problems also having sensory nerve problems?
Not really, unless they have not even stroke, but with motor vehicle accident patients, I do.
Okay.
But not with stroke or any patients, very rare.
Okay. Next question. This is going to be self-promotion. Where can we refer patients to in Cambridge for myofunctional therapy? How much is the treatment cost? How long is the treatment?
Okay, Cambridge. I really don't know anybody in Cambridge, but I do know somebody in Guelph area.
Okay.
All right, and a beautiful girl. She was my student. She worked for me for a long time. Her name is Katrina Basso.
Perhaps, Doctor, we might after tonight connect with you. And is there a directory that we could access for, say, all of Ontario or Canada? We have members Canada-wide. The bulk of tonight's audience is Ontario and Quebec. Is there a place that we can go to or a website that we can go to find folks?
We are working on it, the website.
Okay.
Up, like soon. Whenever it is up, I will let you know. But
okay.
On Katrina's number, I will definitely, make sure to provide you with her contact number.
Okay.
Very much appreciated.
The two sub questions may be hard to answer publicly, but how much is the cost of treatment and how long does it take? I'm sure that depends on the situation, but can you speak to treatment costs and
Yes.
probable treatment times?
Yeah, my session is for 40 minutes is $125. Okay, and that is my assessment, my treatment, everything is 125. And the frequency of the sessions, once a week or twice a week, or even 3 times a week, depends on the severity. How sick, and how long do they take with me? Between 6 to 8 months to be discharged. Yes.
I can almost anticipate the next question. Is it covered by any insurance plans?
For me, I sneak and I put it under my speech language pathology.
Is that an
No,
OHIP covered service?
no, that is insurance.
Okay. All right. Okay. These are always tough questions because most of what we dentists do for our patients, of course, is fee for service, unlike the medical world where it's all free. Until you look at your tax bill, then you know where the money went. Okay. I think that answers that. Next question. Can you comment on releasing tongue ties in adults? A, should it be done? How difficult is it for patients to relearn how to speak and eat after having tongue tie procedures?
Oh, I am always with it. You know, I'm always with the tongue tie release. You know, like when you release the tie, you know, patients themselves will tell you you don't know how much they felt that right at the time when they release that tongue. All that tension is gone on the neck area. You know, and yes, it is difficult for them to eat for a couple of days because it is surgery, you know, because there is stitches there. It depends if it is an anterior or posterior tongue tie. You know, if it is a posterior tongue tie, the oral surgeon has to go a little bit deeper in there, you know, and that for sure, you know, is gonna no pain, no gain.
Right. Thank you. We are very fortunate tonight to have some expertise in our allied fields, and Dr. Sharon Morong, who's been with us for about 6 months, who is an ENT and a sleep physician with an interest in DICE, may want to, if I don't embarrass her too much, come on and maybe add to what you're talking about in terms of tongue tie, because a lot of us have heard about it, but probably wouldn't know where to go, how it's done, whether it's invasive surgery or laser, etc. Do you want to add anything to the options of surgery while we move on to the next one?
Sure. Well, I'm
Hi,
not sure.
Sharon.
Hi, can you hear me?
I can hear you. Sorry if I embarrassed you, but you always have good information for us.
Well, you know, on this one, well, firstly, thank you so much for the talk tonight, because I come from the surgical side, and myofunctional therapy is still, for some reason, an area of controversy when it comes to sleep apnea surgery. So we don't get to hear or learn much about it. When it comes to the posterior tongue tie, that too is a topic of debate. But in terms of having the posterior tongue tie done, typically it would be the oral surgeon. ENTs, we do posterior tongue ties, but more so in children compared to adults, just because, you know, we haven't reached there yet in terms of being fully convinced that it works. From the literature that has been done by surgeons like Zaghi in California, I think that I totally agree that it can help a patient, but it is hard to find a medical surgeon who will do it. It's more on the oral surgery side. In terms of the techniques, you know, you have the typical cold technique of just using a pair of scissors with stitching. In the States, they use laser as well, but I don't think you would actually have that. I don't know of anyone who uses laser here, but they could be. But it is more on the oral surgery side. ENT was still lagging behind a little bit when it comes to posterior tongue ties for sleep apnea.
Well, thank you, Sharon. You wouldn't be referring to the silo concept of healthcare, would you?
I'm always referring to that.
Okay. Well, thank you for being there, and feel free to jump in if any of the questions you think you could add to.
Sure.
Okay, so I think that covers that one. Which tongue muscles pushes against the palate? Which tongue muscles push against the palate? Dr. Mohammed.
Yeah, which tongue muscle that pushes again is the palate. You know, the whole muscles have, you know, like all tongue muscles has to work together. You know, like you need your transfer muscles to bring your tongue in. Okay, you need your genoglossus muscle, because that genoglossus muscle is a little bit, you know, like a fan shape muscle that is shortening the tongue, you know, and put it up. And also you need as well the lift, the styloglossus. So to bring the tongue back, and the palatoglossus to bring it up. So you need all these muscles to actually work together to for the sucking up your tongue on the roof.
Okay, next question. Does age decrease the effectiveness of myofunctional therapy?
Oh,
Can an old guy like me be helped?
I think it does. You know, like I don't want to, you know, like I work with anybody and everybody. I have a patient that who's 103 years old.
103, wow.
103. And my belief is, as long as somebody is breathing in and out, I work with them. You know, like I don't say, oh, they're too old, they're too, you know, like breathing in and out. You come to my clinic, I'm going to take care of you. That's what I believe in.
Okay, excellent. Another multi-part question. I'll try to parse it for you. When you have sensory tongue problems, patients tend to eat on one side only, which then affects their neck muscles atrophying on the side where that's not functioning. People tend to eat on the side where they're able to taste their food. Do you get involved in neck muscle function yourself?
If I understood the question correctly, yes, it does. You know, like anything that if you sleep on one side all night long, that is going to affect your jaw. That is going to affect your sleep. If you have that noxious behavior of, you know, like resting on your, you know, like the fist of your arm like that, that is going to affect your jaw. If you are eating on one side, because if you are eating on one side, what is happening? What is happening is that you are actually using, because if the lateral pterygoid on the right side that move the left side of your jaw, and the left lateral pterygoid is moving the right side when you chew. When I'm chewing now on the right side, I'm using my left lateral pterygoid. So if you are using one side of chewing, that always, you know, like that lateral pterygoid is working, and this is on rest for a very long time. Then that is going to affect the symmetry of your face, is breathing, and, you know, like, and later on is going to be a problem when you age. You know, like you know, like you really age, and then you have a little bit that is comorbidity kind of, you know, it affects you. And I have people like that, and I said, I wish if I have seen them 20 years ago, from preventing them from going to tube feed for no reason. Because temporal, you know, like oral facial disorder or oral myology disorder, most of it because of a tongue thrust, because of a tongue forward. So if your tongue is always forward, what is happening? What is happening is the proximity between the base of your tongue and the pharyngeal wall is bigger. And you need that proximity to be closer for you to swallow your food. That when you go for an assessment, modified barium swallow test at the hospital, you will see or hear that term, base tongue retraction problem. So that is a problem. That's a retraction. You need that seal between the base of the tongue and the pharyngeal wall. So if your tongue is forward, but you're functioning for, for a long time, when you get really older and then you have any problem, it is very hard to swallow your food. Then you go for aspiration and aspiration pneumonia and blah, 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 and a lot of things like that. Does that make sense?
Yes, absolutely.
Okay. Thanks.
Now, there are a couple of things you need to hear which are not questions. Typically, some folks leave before the night's out, and there are a couple of comments directly to you. You were awesome, Dr. Mohammed. Thank you so much. Another one, thank you for great information. Come back again, that sort of thing. So clearly, what I said at the outset, you're a bright light because we learned about this many years ago, some of us many more years ago than others. So your presence is greatly appreciated. Back to the questions. This was a business one. I have a myofunctional therapist in Cambridge, same city as the other question, that charges $2,500 for a 6-month treatment program for children. Does that seem reasonable to you?
Thank you so very much for whoever asked that question. The problem with that, when I tell my patients and my students that I am a clinician, I'm not a magician. And when I tell you, Dr. Rostam, that if you give me 2,500 for 6 months, I have to deliver after 6 months.
Okay.
But I might not able to deliver after 6 months because I'm a clinician. So I charge per session. Whenever they feel they are not getting the benefit, they can stop.
Okay. That's a good philosophy.
Yeah, if I give you 2,500 for this, then after you give me 2,500, then after 6 months I have to deliver. There is no way. And I might not able to deliver.
I'm a clinician, not a magician. I love that. That's great. So often we're expected to do magic.
Yes.
And usually to disgruntled patients who want it for free.
Yep.
Back to the science. How about upper lip tie release? How about upper lip tie release?
I am, it depends when you test your patients and you test the lip competency. The lip competency, we use a gauge, like a meter. And if it is, like that meter, it it is 3.5 pounds that you and above, you are fine. Less than 3.5, then you consider to have lip incompetency issue. So if you have lip incompetency issue according to the scale and you have a lip tie, then I might ask you to go to do a lip tie release.
Okay, thank you. As always, I promise to read every question. This may have been covered by you and Dr. Morong, but is it better to release a tongue tie with laser or with scalpel? And I'll allow each of you to answer if you feel that's appropriate.
Go ahead.
Basically, tongue tie, laser versus surgery. Sharon, do you have anything?
Yeah, I don't, well, from the literature, there's no evidence to say one is better than the other. I know in the States, again, I can't speak to here, but laser is definitely used for children. It's said to be less painful after having that procedure done. But whereas with using the scissors and stitches, that's more so used for adults. But again, this is mostly off of the data from the States. Any oral surgery colleagues here may be able to talk about what's happening here in Canada.
Okay, thank you. Can myofunctional therapy help with REM-related OSA? Dr. Mohammed, can myofunctional therapy help with REM-related OSA?
I really don't know the answer to that question.
Okay.
Right.
Okay. All right. That's okay. You're all right. Remember, it's a lifelong learning. You don't have to know it all. Okay, now we have a success story, and some of my colleagues will know this particular practitioner. So Dr. Herman Ramirez, who's in the Toronto area, just released the lingual freedom for my 8-year-old daughter, then MyoBrace, which is a myofunctional therapy appliance you're probably aware of. My goodness, within a week, she stopped rubbing her eyes during the day and looked more alert. Lots of tongue exercises to prevent reattachment at original location. Now she's doing breathing exercises. You may even know who we're talking about. Dr. Ramirez is well known in the dental field.
I know him personally.
You know him personally? Okay. He was in Winnipeg for a long time, I think.
Yeah, he's in Aurora now.
Yes. He came from South America to Winnipeg in the winter. Bad idea. He found out that there's better places to live. Okay. This maybe already been answered. Does a patient need to have myofunctional therapy before the tongue tie release as well as after the release?
Yes.
Okay. Alrighty. Does Dr. Muhammad have a good resource for myofunctional exercises that he endorses with the exercises being done properly? You may have spoken about that in your upcoming book. So maybe just review that again.
Okay. So, like, because again, I always try to, one of my problems, and I'm trying to, I'm getting older to stay away from it. I'm a perfectionist. And being a perfectionist is a problem. And if you are a perfectionist, try not to be, because it will stop you from doing a lot of good stuff, okay? So I hate to see people doing, they have the intention to do the right things, but they do it the wrong way, and that bothers me. That's why I came up with the idea of this book. And to make sure that actually people are doing it right, not only written, but also a visual thing. I want them to make sure, because we have, an asymmetrical smile, right? We have some people that have asymmetrical smile, like Alpha's smile, Alpha's Presley smile, So you need, when your patients come to your clinic and they give you that smile, immediately we need to know which muscle is not working. The risorius muscle is not working properly. Okay, so how do you fix it? That is again the question. Okay, so I'm sorry.
Okay, no, that's fine. Again, this may have been covered, but the same person asked, are these exercises more helpful in mild or moderate or severe OSA?
Like all of them, for mild, moderate, and severe, because like any progress is a progress. Like if you make, sometimes you make 20% progress, sometimes you make it 80, sometimes 70, but any progress with OSA is a progress, and you know it.
Thank you very much for that.
Yeah. Is there a role for myofunctional therapy in patients who are having difficulty with their current treatment, be it CPAP or their oral appliance? Would myofunctional therapy help improve compliance in these patients? Or do we know if it can help?
I really don't know if there is any literature out there about this specific topic.
Okay.
I guess yes, it should help. Because anything helps. And I have patients that they come to me for other issues like swallowing, blah blah blah, and they ask me about the oxygen therapy, for example. Mm-hmm. And I said, can you afford it? We said, yeah. I said, go for it, because I don't want you to stay with what if I did it, what if I did it, what if I did it. So I always recommend to people, if they can afford it, or if it is covered by OHIP, go ahead and try it. Okay, like what didn't work for me, it could work for you. It's very simple. And again, like Dr. Sharon, I love disagreement more than agreement, because I think we improved by disagreement. not by agreement. When if we agree on everything, we will never, like improve. We'll never do anything.
Mhm.
Disagreement make us, on that challenge mode and new more and move. So I'm always with that. But I to be back to your question, I think you need to encourage your patients to try orofacial myofunctional therapy.
And I have another question. Do you find that weight or BMI, does that affect the success of myofunctional therapy?
Yes, of course it does. Okay, it does. Why? Because when you work with patients that their BMI is very big, like that affect their tongue muscles, affect how they walk, because if they have a big trunk,
Mhm.
that affect their posture, the way the way they walk. And when you have patients that they are sitting with head forward posture like that, that is affecting their back, affecting their breathing, affecting everything. And actually they are running in the street. I see them and I say, oh, they think they're doing a good thing for themselves, and actually they are hurting themselves. So definitely BMI does affect, sleep, or orofacial myofunctional therapy. It does affect it.
Thank you.
Thank you, Sharon. Dr. Laurie Jones would like to ask a question.
I want to thank Dr. Mohammed for his presentation today. He had some really cool gems that he shared. My question has to do with the complexity of adults. Now, I don't treat like Dr. Rawson. I don't treat children, and so in my practice, I treat adults who have been injured in various ways. And they are usually chronic concussion patients. It is my finding that there are timings that are issued in the treatment of these patients. They have complex problems, and they come sometimes I'm in the front of the line with my therapies, and sometimes I'm at the end of the line in my therapies. But I also have a suspicion that myofunctional therapy is a lot like what I do. There are times when myofunctional therapy has to stand aside and allow other therapists to do their work before in my case, me, but I'm wondering in Dr. Mohammed's case, that he has to stand aside and let other people come first. In what circumstances do you stand aside and not introduce myotherapy until later on in the process of recovery of complex chronic pain patients?
The good news is, like most of my patients, they come from referral sites. They tried with them everything.
Yeah.
And I don't know if it's fortunately or unfortunately, I become like the last resort.
Yeah.
When they do anything and everything and nothing is working, then they ship them to poor Muhammad.
I can relate to that.
So when they come to me, they already, used all these resources. So I don't have to, withdraw myself, and then do anything, and I said, oh, you need to do that, Paris. Sometimes I do. Sometimes, like I really, this morning I was the oxygen therapy patient, and I said, hey, you are doing it too much. You are coming here, you're going to physiotherapy, you're going, osteopath, you're going to, coming here. Why, Lou, just take, choose two therapy not to go to. And he said, what do you recommend? I said, I recommend to stop coming here because you are doing so well with me. Okay, and just continue doing your oxygen and do your physiotherapy, and then in 2 months, call me back. Like I have done that. Okay, not because there is any contradiction with therapy, but because I felt it is just too much.
Yeah.
Like he leaves home at 7 o'clock in the morning to go to oxygen therapy for 2 hours and then go to physio and then come to see me. And then, that is too much. And sometimes these patients, we need to tell them, hey, you need to slow down. You're not doing any good to yourself by going everywhere.
I think that's a very insightful answer. But did I hear you say you started treatment in this particular patient and then you said stop? I'm wondering, do you stand aside and say, I won't start until, for instance, your SCMs aren't as tight as they are, or your anterior head protrusion is not a 35-degree angle?
No. Like I don't, when I do my assessment and they come for, like sometimes if they have seizures, I do a step aside until they control their seizures. Like that is for sure, 110%. Like I said, no, like you need to work on that first, because I don't know when you have your next episodes. And I don't want you to have it while you are here in this clinic. So that I do. But in most of the other cases, as I said earlier, I am the last resort. They send them to me when they're done with everything. Okay, and then go to Muhammad, and then I try to, I'm just working with, I don't know, I'm sorry, Dr. David, but I have just to elaborate on this a bit. I have a patient with tinnitus,
Tinnitus, right?
like, and like, and he has been with, like everywhere. Did I am able to treat him? No, I am not. Did I am able to help him? Yes. Like it comes to me with that, like ringing sounds in his ears. Up, he said, on a scale of 1 to 10, it is always between 5 and 7 on both ears. When he starts coming here, did it disappear? No, it didn't. But it went down to 4, to 3, to 2, to 1.5 now. And now he stops for a week, 2 weeks, and then he comes back. Then when I come here, it really helps me. Like I can do my job, I can live with 1.5. But 7 is too much for me to take. Why he came? He came because he went everywhere. And I start working with him, and I said immediately at the beginning, I'm not a magician, I'm a clinician. I will do my best to help you out. But I don't know where we are going with this.
Fair. Well, thank you. We have another, sorry, Laurie, am I cutting you off?
No, thank you. I appreciate his sincerity and his thoughtfulness in his answer. Thank you.
And we appreciate your questions. They're always very focused, and we only hire the best people to be here when you come. Okay, and I'm joking. Rhonda Stevens has an oral question. Rhonda?
Yes, I'm just wondering about finding therapists and if this type of therapy can be done over the internet.
If I'm doing my therapy virtually, I would be rich by now. Because people are calling me from India and Germany, and like they're all over. They're calling, can you do it virtually? And I tell people, I felt like, like as if I'm cheating you guys.
Yeah.
If I don't palpitate these muscles myself with my own fingers, my own hands, I don't start therapy.
Okay.
Then I see patients for a little while. And then if I feel like they are eligible to be seen virtually, then I do virtual. But every 4 or 5 sessions, they have to come in.
So
But-
then I guess the next question would be locating a therapist in your area. Is it difficult to find people?
In my area,
I'm in Vancouver.
Vancouver. Ooh. I can look for someone in Vancouver.
Okay.
And if you like, I hope like if you want my my number, if you have a pen handy, 905 302 0998.
Pramila Meehan. Thank you. You have the floor.
Thank you. Dr. Mohammed, thank you so much for your webinar today. I've been so excited to meet you today. It's been wonderful. I've learned so much today. Thank you so much. I wanted to ask you a question about tongue ties. So for the last 4 or 5 months, I've been really taking time to check my patients to see if they are tongue tied, and I've been making notations about it. I really don't know what to do with that information because I don't know of OMTs in my area. I don't know which patient should be seen to have myofunctional therapy. I can't figure out who should have their tongue tie release. I don't really know what to do with that information.
Like I like it because also it has an scale.
Yes.
Anybody to out for it.
Yes.
Okay, we measure it.
Yes.
And then according to that measure, then and also about functionality as well.
Right. Right.
So if it is functional, if it is mobile, if it is, like I'm with it 100% all the time. But if a patient is really scary, they don't want to go for it, and the tongue is mobile and doing the right thing, and like, why bother?
Right. Yeah. So it's more for my patients because I do my sleep disorder questions, sleep health questions. So these are the patients that have a lot of symptoms of sleep disorder. And then I check the tongue and it's tongue tied. And I say to them, I don't know what to do with that information, but let's start you working through your sleep disorder. Okay.
You test if they are hypersensitive gag reflex.
Okay.
You have to release it.
Okay. Okay.
Because most of them with a tongue-tied patient,
Yeah.
people, I want you to listen to this. This is my discovery, okay? A tongue-tied patient, they, like they present most of them with hypersensitive gag reflex.
Okay.
So the hypersensitivity of the gag reflex is my parameter to send them or not to send them, or one of the parameters or one of the indicators.
What about for some women, when you ask them to move their tongue, you can see all the muscles in the neck just get super tight, and you can just see the collarbone move and the neck muscles get tight. They're also the ones that don't want any treatment, that have to research everything before they go anywhere. How do you approach those kinds of patients?
Like I'm not a counselor, but I try my best to tell patient, I said, like you have to make sure, that you don't know until you try.
Yeah.
Like, and a lot of patients, I swear to God, I wish if you can come and visit me in my clinic and see my patients. And I'm seeing one from, like a patient from your area, from Kitchener. I can't say his name because he's my patient, and he said, like, go ahead and,
Yeah.
And and he said it is a life changing. It is
Mhm. Yeah.
Like he, like, and a lot of patients that they come to see me actually from Kitchener, from Hamilton, from, I have patients that are coming to see me from weekly. They come from Montreal.
Mm.
And
Okay.
they are not stupid patients.
No. Yeah. Yeah.
They don't see progress. They don't keep coming.
Right. Right.
But I'm very easygoing. I talk to them and I said, hey, like, you let me, if you don't make any progress, there is no hard feelings here. You are taking the trip, you are paying the money. I listen to you, I listen to my patients, and I make sure that I don't hear them. I listen to them
Mhm.
and I respect their decisions. He said, oh, Dr. So-and-so said, if I don't go and take myofunctional therapy, he's not gonna put braces on me.
No, yeah,
Who cares? It is your mouth.
yeah.
If you don't want to come to see me, you don't have to see me. You
Mhm,
go somewhere else and put that damn braces in. It is
mhm.
mouth.
Right.
So I am always pro patients. It is not about me. It is about them. But
Mhm.
we need to find out the right key to use to convince them this is for your own best interest.
Okay. Thank you.
Okay.
Thank you very much. Thank you.
So all credit goes to you. You brought us information that most of us have thought about, but didn't really know how to use in our practice, as evidenced by the questions tonight. So thank you so much. I can see a need to bring you back maybe in the fall and build on this subject, because the more you learn, the more you want to know.
No problem. Anytime. Thank you so much.
Okay.